First of all, once again, welcome to yet another session of BRENDOS. For those who are new to this forum, BRENDOS is the Breast and Endocrine Society of Western Uttar Pradesh. Myself, Dr. Sudhi Agrawal Kamboj, I am the first and the only breast and endocrine surgeon in the whole Western Uttar Pradesh. So, this was my very important responsibility and task to create awareness, not among the general masses, but among the doctors also about the breast and endocrine related disorders. And keeping this in mind, we have started this forum around 3 years back. And since then, we are successfully running this program. And on a monthly basis, we have online meeting where on the last Friday of the month, we conduct the meeting with breast meets on every even month and endocrine meet on every odd month. So we have a perfect balance, and we discuss about the clinical problems of the day-to-day clinical problems. We just try to find out the solutions of that. And we both to have a WhatsApp group with more than 600 doctors, not only from India, but also worldwide. And this is a very organic growth. We are achieving this milestone for past three with consistent efforts of last 3 years. This is our second intercontinental meet. Thank you very much, everyone, for making it happen. And why we have chosen this topic? Reason being, congenital breast disorder is a very common problem. It is a common problem. We see those cases in our day-to-day clinical practice. But as we know, in India, it is very difficult to have robust data about the demographies, about the incidences, prevalences. And in congenital breast disorder, since it is most of the time benign breast disorder, so it is never reported. Nobody bothers to just find out the exact incidence, the prevalence. But it has a huge impact on patient's mind because, first of all, it causes a cosmetic concern, which is no doubt it is not only about healthy body, it is also about healthy mind. So whenever there is some cosmetic deformity in anybody's body, especially any sexual body, then certainly the other, it creates some psychological disturbance, which most of the time we underestimate. Secondly, it causes some physiological and pathological changes in the form. Suppose if there is inverted nipple, definitely apart from the cosmesis, it hampers the function, and the patient they presents with multiple recurrent infection, periductal mastitis. Same with other thing. So this topic is very important because though as a breast surgeon, as a plastic surgeon, we many times operate these cases, but it is always good if we get an opportunity to learn from someone more learned, more experienced, so that we can redefine our surgical practices. So with this, now I would like to introduce one of our moderators, uh, Dr. Ajay
Dr.
Sharma.
Ajay Sharma.
One of
One of
No problem. I can speak for myself. No problem. My name is Ajay Sharma. I'm a transplant surgeon. In my previous life, I used to be breast and endocrine surgeon when I worked in GPJ Lucknow for 3 years. And I must say that my experience of congenital breast disorders is almost nil. Nobody presented to us at that time. Later on, as the department expanded, it has had such amazing registrars who are now very famous breast and endocrine surgeons, as Sudhi is. I have had immense privilege of watching her operating on a thyroid by minimally invasive technique. So I'm here to introduce the faculty. The main faculty is Dr. Sanjay Mukherjee. And before that, I thought it is worthwhile introducing one of the guest faculty is Dr. Professor Manish Singhal. Manish, I know since we started ACC, Critical Care course in Trauma Center, and I was introduced to him as a plastic surgeon. He has been in AIMS surgery department for 20 years and 10 years having been a faculty member in the plastic surgery department. So yeah, wonderful to see you, Manish. Any experience of handling the congenital breast disorders, Manish? Do you have any experience of any patients who come to you with the congenital breast disorders?
Yes, sir. Very frequently. I think
I
they
think
from my side.
my side. Yeah, Manish, if you can share your experience just quickly, just for the purpose of introduction,
There
as
is
to
echo some. Let me check, sir. There is some echo from which side, sir? I can speak, no problem.
There is
So
some echo, I think, Hana? There is some echo.
yes, sir.
It's gone. Manish, the echo is gone. Go ahead.
Okay. Just a second. Huh. So, sir, we have a lot of experience in congenital breast disorders. Specifically, I think we mainly see Poland syndrome with hand anomalies quite often, and we also see some accessory nipples and some breast asymmetry quite often in young girls. This is something which we see quite often in our practice.
that is amazing that you can really got expertise to manage these girls for whom it can be quite distressing. So it will be great to have your comments later on after we listen to Sanjay Mukherjee. Sanjay Mukherjee is my class friend from 1980 batch of AIMS, so I know him for more than 4 decades now. We So I would request everybody to switch off their, mute yourself so that we can really listen to the speaker. So Sanjay Mukherjee is a very famous breast surgeon, breast reconstructive surgeon.
Excuse me. Hello, Dr. Sudhi. Dr. Sudhi.
Yes, sir. Yes, sir.
I want to just join for 5 minutes and then I'll switch off because
Yes, sir. If you can
I've been
say a
traveling
few
this
words,
morning, no? So,
Doc-
okay. If you permit.
Yes, sir. I was looking for you actually, Professor
thank you.
Anurag Srivastava. Who
Ji,
does he
ji,
need? Does he need introduction? HOD of surgery at AIMS previously, and now the head of Cancer Surgery Institute in Subharti. Sir, please go ahead.
Today, actually, I have joined in a new position. I'm going to serve as the principal and the dean and head of surgery at Mahayogi Gorakhnath University Medical College in Gorakhpur. So I've
Wow,
joined
my
since today.
God! Many
So I'm
congratulations.
actually speaking from Gorakhpur.
Many
So
congratulations, sir.
thank you. So can I just show? I'll just take 5 minutes. This is for teaching residents and other surgeons if they want. Hello,
Hello. Yes, sir.
Yes, sir. Please go ahead, sir.
डॉक्टर सुधी. तो
Yes, sir.
एक पेपर में मैंने थोड़ा सा बनाया है, उसको कैसे दिखाएं?
Sir, I make you co-host, sir. आपको
अच्छा,
co-host
हाँ, ठीक, वो करिए.
जी,
तो
sir.
हाँ,
Sir, आप
तो
मोबाइल
pardon me for just barging in. So I thought
Dr.
that I'll
Sudhi,
just share
I
some
think sir can
thoughts.
WhatsApp you and you can project. I think that will be easier for everyone.
Yeah,
I
that
think.
will be easy. Sir, you can
हाँ.
WhatsApp me, sir. I project and then you explain, sir.
नहीं, वो एक पेपर में मैंने लिख लिया है.
जी,
जैसे
sir.
मैं पढ़ाता हूँ ना कि निपल इन्वर्जन इज कॉन्जेनिटल, तो उसमें N for N, there are 2 N's in inversion, 2 N's in congenital. तो मैं I've just written on a paper. So if I could project that from the screen,
Yes, sir. Yes,
is
sir.
that permitted? Is that okay?
So you do it from I make you co-host, sir.
हाँ, so if you open the video,
Okay, sir.
okay, sir.
It is simple, sir. If you can show it on the screen just like that, we would be able to read that.
So
very
please
clearly.
allow that.
That is
Can you see this?
Yes, sir. Yes, sir.
Can anybody read it? Nipple inversion is congenital. N for N. There are 2 N's in inversion and 2 N's in congenital. Right? Whereas nipple retraction is acquired. R for R. Retraction has a R and acquired has a R. So R for R, retraction, acquired phenomenon. Inversion is a congenital, right? And inversion is because of the fact that the milk ducts do not elongate more than the rest of the breast tissue. So the nipple remains inside. So nipple has never seen the light of the day or the night also. So there is no cancer risk attached to it. But if it is of severe degree, then it may hamper or make the breastfeeding, feeding the baby difficult, right? And the minor degrees, due to just spasm or shortening of the muscles, may be corrected by just teaching the girl to pull the nipple, or sometimes you can have a syringe. Take a 20 cc syringe and then cut the top. So if this is the syringe, take the and right. So cut the top of the needle syringe, 20 cc syringe with a warm knife. You can cut it and then reverse the plunger. So plunger should go from this end, and this end will sit on the over the areola. And when you take the pull the plunger, it creates vacuum in this 20 cc syringe and pulls the nipple inside. So that's a very simple way of pulling the nipple, minor degrees of nipple. And this also helps in breastfeeding if there is lady is finding it difficult to feed. So 20 cc syringe cut on the near the tip. So that is inversion, whereas retraction is an acquired phenomena, and all doctors should know that if it is a recent onset retraction, they should rule out cancer because there is desmoplastic reaction in and around the milk ducts which pull the nipple inside. So recent onset retraction, especially 30 plus age group, always rule out cancer. And if it is long standing for many years, it is due to fibrosis in and around the milk ducts due to periductal mastitis. So long standing periductal mastitis and short onset cancer. And how do we know that lady has inversion or retraction? Ask one question. Question is, Madam, did you breastfeed the baby? Mataji, क्या आपने बच्चे को दूध पिलाया था? If she says yes, she breastfed, that means the nipple was out and then it has gone in. So it is retraction. If she could not feed the baby, probably she has inversion. So I think I'll stop here. Thank you very much. Thank you. Thank you.
Thank you.
Thank you, sir.
Thank you.
We'll come directly to Sanjay Mukherjee, Dr. Sanjay Mukherjee, plastic surgeon from
Please,
California
please,
and
please.
South Dakota. Thanks very much, Sanjay, for leading this show today.
No problem. Thank you. So, everybody can hear me?
Yes, sir. You are very well audible, sir.
Okay, and I just wanted to get back to the screen that I had. Give me 1 second.
Yes, sir.
The screen sharing.
Later on, we'll have some comments from Anjana Satpathy also, my colleague from Manchester region. She's a breast surgeon there, so it will be good to have some comments from her as well.
Can everybody see the...
Yes, sir. But there is some echo, sir. I hope there is.
Yeah, I can hear my voice echoing. 1 second.
Yes, sir.
How about now? Is there an echo still?
Better, sir.
Okay. So this is just a short slide presentation. There are not too many slides. I didn't put in a whole lot of material. So if anybody wants to stop and ask me some questions about the material, you can do that rather than me giving the whole talk. So this, if we just talk about 1 or 2 subjects at a time, that's fine. So the way I think about this with congenital breast disorders, we have to remember that the breast mainly develop for a woman during her teenage years. So you really won't be able to see clear-cut disorders until you wait till they fully develop, which would be about 18 or so. But you can see some things that they're born with that don't need breast development. And as one of the other speakers referred to, one of those conditions would be something like Poland syndrome, where you're born with an absent pectoralis major, maybe even the breast and the nipple might be missing on that side. You would have some arm problems. So all of those would be apparent when the child is born. So just to give you an overview of the things we might be talking about today, inverted nipple, we already heard a very good material from one of the faculty. The next thing I want to talk about would be tuberous breast, which is fairly common. breasts, part of the axillary breasts. That would really, it's really part of the normal anatomy, but it might be something that a patient might complain about. Is everybody here still?
Yeah.
Okay,
Yes,
sorry.
sir, we are
We are there with you.
Axillary breast very.
Say that again, Sudhi.
So these conditions are very common. We very commonly
Right.
see these conditions in our setup.
Okay. And then supernumerary nipples, which are like extra nipples along the milk line. When the breasts develop, they may not be perfectly symmetrical. There might be differences. Some may not be cosmetically significant, but others would be fairly significant and would need correction. Otherwise, there's going to be a massive difference between the two sides. Aplastic breasts and hypoplastic breasts, and that's really one of the commonest things I see as a cosmetic surgeon over here. Where people are coming in for breast augmentation. And then gynecomastia, which is the development of or presence of visible breast tissue in a male. And this can be, the commonest is its cause is usually idiopathic, and it's during the teen years, and that's when they're very aware of their appearance. And so they come in for cosmetic surgery for that. Otherwise, you might see it in a later stage when the males are on maybe some kind of treatment with estrogen. For example, somebody that's got prostate cancer, it might be one of the treatments that they're on. So this is an example of somebody that has a lot of the abnormalities that you see in Poland syndrome. But it might be something very subtle. For example, you can look out here and you can see on the right side, the fold, the anterior axillary fold is formed by the pectoralis major muscle, whereas on the left side, you can see that there's no fold like that. So just the difference in the folds gives you a little bit of a clue that they may be missing their pec major on that side. And partially that's why she also has this asymmetry between one side to the other. This is an interesting case that I've followed for a number of years in my practice. I've been practicing up here since the year 2000. And so I followed this patient for the last 25 years or so. And when she came in to see me, she was 19 years old, and she had, you'll see quite a few different conditions in her. One is obviously very apparent is the asymmetry that she has from one side to the other. She has these large areola. It's a narrow base, so there's a lot. Even if they were somewhat symmetrical, there would be a big difference in the cleavage, how far apart each breast is. The nipples will be pointing downwards. Most of the breast tissue is on the superior pole of the breast, and the distance between the nipple and the fold, inframammary fold, is much less than normal, and that causes what we call the droopy breast. And the breast can often be tube-like, oval, or triangular, so they won't appear like the round breast that we think of as normal. And the breasts themselves will be fairly small. They lack volume. So these are, and again, that's one of the things that always interested me in plastic surgery, was that you have to customize the treatment plan that you have based upon the patient's anatomy, pathology. And so there's not any cookie cutter kind of surgery that you can do for these patients. The principles in general are that you want to redistribute the tissue. So you want to make sure that there's enough tissue on the lower part of the breast. You need to relax the skin, because some of the skin can be really, really tight on these patients. Like you can see over here, she's got very little skin, and you want to be able to stretch it so that the envelope that is formed is big enough to accommodate whether you're putting in an implant or you're putting in fat, whatever you need to do to make the shape more breast-like. If someone has really, really small breasts and you want to get them up to the size that like she has, like in this patient, you definitely need implants. If they have just a slight amount of volume that you want to add, then you can use fat transfer, where you aspirate fat from some of the body area where they have excess fat, use liposuction, and you can transfer it. I generally don't like doing a lot of fat transfer. I've done them multiple times, But the biggest problem with this is that it's an unreliable technique in terms of the fat surviving, especially if you're doing large volume transfers. So implants are much more reliable. Whatever volume you put in is the volume that you're going to get. You don't lose any in the post-operative period. The biggest thing, the judgment call that you have to make as a plastic surgeon is to decide upon the size that you want to achieve. And you want to prepare the patient mentally that it might be more than a single stage result, because it might take time for the envelope to stretch out. And if it's really, really tight, you might need to even put in a tissue expander as an intermediate procedure to stretch out the skin, and then put in the final size implant. Also, if there's asymmetry between the two sides, you want to get them to be somewhat similar in size, but you need to talk to the patient and make sure they have reasonable expectations that they're never going to be perfectly symmetrical. And this is the result on this patient. And she came in, I mean, this is obviously right post-operative. And you can see she did very, very well with just implants being put in, the tissue being relaxed. And on this left side, I made the areola smaller and did a lift on this side. Otherwise, if you don't tighten up the skin a little bit, then both the sides will have a very different shape from each other. She finally came in to see me about, I think this was about 3 or 4 years, maybe 3 years ago. And the first question to me was, when are you going to retire? Because she wanted to make sure she got a surgery by me before I retired. So I said, I haven't made up my mind yet. But we basically, she had become, from age 20 to age 34, she had become a little bit heavier. So she wanted slightly bigger implants. So all we did in this instance was just change her implants out and put in slightly larger implants. But just the first surgery itself was enough to correct most of her deformities with this. We already talked a little bit about the inverted nipple. And this is an example of a patient that has an inverted nipple. This is something that was caused by the milk ducts being a little bit shorter on that side. And usually this is something that I can correct in the office. And I like we talked about the suction technique with the syringe for people that have mild inversion. It's pretty interesting out here in the US. A lot of the women, they have pierced nipples. So that's actually not a bad technique to, when you correct the inversion, you can use the piercing with a metal rod to hold out the nipple in position and make sure it doesn't slip back. So that might be a cultural thing, obviously. I'm sure it's not that common yet in India, but it's not uncommon out here. So the procedure that I use to correct an inverted nipple, usually something I do in the office under local anesthesia. I would pull the nipple out with a larger suture, like maybe a 3/0 suture going right through the nipple, and use that as a traction to pull the nipple out. So, and then subsequently make a small stab incision with maybe an 11 blade, which is the little triangular blade, probably around 6 o'clock, so just at the nipple areola junction. And that would be barely 3 or 4 millimeters in size. And through that incision, I would make various sweeping cuts at the base of the nipple. And that would release the milk ducts and whatever fibrous bands are holding the nipple down in an inverted position. So once you release enough of them, hopefully then there won't be that pulling or retraction of the nipple anymore. I would also put a purse string suture, which is a finer suture, or maybe like a 5/0 nylon or proline, which would be in a purse string configuration around the base of the nipple. So once we tighten that out, then you really are making sure that there's some kind of an obstruction to the nipple slipping back into the breast tissue. And then I would use that stay suture that I'd put in initially, and I would tape that to the skin and leave it like that, taped for 1 week, so that it puts some traction on the nipple. In spite of all these precautions. Sometimes the nipple can slip back in, but it's fairly easy to bring them back. Just remove the stay suture. Use or just repeat the procedure. And because it's in the office, barely takes 10 or 15 minutes to do. It's a fairly easy procedure to repeat. We talked a little bit about an axillary breast, and that's an example of somebody that has this tissue in her axillary area. This is actually part of the normal anatomy. It's just a little bit more prominent. And that's the axillary tail of Spence, because the breast itself is a circular organ, but it has an extension which is like a tail-like, but it's extends into the axillary region. I've tried liposuction. I really don't like it because it doesn't give you a complete flattening, and the incision is obviously with the liposuction, the incisions are maybe 4 or 5 millimeters in size. I prefer that direct excision myself, and there's a small incision that you can make right over the swelling and remove the entire tail. And the only reason to remove it is for cosmetic reasons. It's really nothing to worry about functionally. Supernumerary nipples can be mainly situated along this milk line that you can see, which resembles the milk line of various mammals. And depending upon if somebody wants it removed, then it would be just a simple question of excising it with a skin incision. There's really usually not much breast tissue underneath these supernumerary nipples. The main breast tissue would be where it is normally located. Sometimes there can be some breast tissue, and then you might have to excise that as well. The hypoplastic breast, that's obviously one of the commonest things that we see cosmetically. I was just gathering some information. I believe it was more than what I expected. The cost of getting a cosmetic breast augmentation in India is, if I'm not mistaken, and depending upon where the surgeon is located, in a bigger city or a smaller town or whatever, it ranges about $2,500 or so. Ajay, am I right? What's that figure in rupees? Hello?
Sir, we can hear you.
Okay, yeah. So that would work out to
From $1,000 to $2,500. You're
yeah,
right.
That's I'm not able to translate that into rupees, but that's the amount. Out here, again, depending upon the surgeon, etc., the usual thing with including all the anesthesia, the cost of the implants, etc., it's probably in the $5,000 to $8,000 range. But again, it depends upon what kind of location you're doing it in, etc. The usual, is that mine? Is that mark mine, or is it from somebody else on the? Okay, so the incisions are usually either inframammary fold, circumammary, or axillary. And the location of the implant is can be on top of the pectoralis major muscle, which is subglandular. Most of mine are submuscular, which is behind the pectoralis major. So I make the compartment in between the below the pectoralis major and the rib cage, and I would make that pocket, and I would actually divide part of the insertion of the pectoralis major on the lower part, because that would allow the implant to sit in the correct place. When I started initially, I was not making those incisions in the pectoralis major, and the implant then tends to get constricted and pushed laterally and downwards by the pec major. But if you divide the lower part of the pec major, then the implant usually sits in the correct place. And I've started. There was a time where there was a lot of litigation going on about implants, and they were only for the silicone implants, and they're all made of silicone shells, what's inside it can be either saline, so you fill it, you put it in empty, you pump it up, and then pull out the filling tube, and then you have a saline filled implant.
Yeah, this is not safe at all the way you're doing this.
I'm sorry.
So take the rainy time.
Don't worry, this is just a distraction.
Okay.
This is my comment on you, not a comment on you.
Okay, or you can have an implant that comes in pre-filled with silicone gel, and they're in various sizes. The tricky part about the surgery in terms of keeping the patient happy with the final result is to kind of understand what size they want to be, and there's some guesswork involved in that. But we usually have them try it on in a well-fitting bra, so that they know what size they would approximately be when the implant is inside them. And they come in fairly close numbers, about 40 or 50 cc's apart. And so you have to make that decision either beforehand, or you can have the implants, multiple size implants in the operating room, and put in the ones that you think are going to be satisfying to the patient. I've found in my practice that letting the patient make the decision causes less controversy, whereas if you make the decision for them, then they might feel less happy about the end result. So we let them size themselves. And this is an example of a male patient, teenager, about 15 or 16 years old. You can barely see some of the breast tissue that he has. But it was enough to distress the patient, and there were the other children in his classroom, etc., were making fun of him, and he felt unable to take his shirt off in front of the others in the locker room. So he had plenty of reasons that he was unhappy with them. But if you look at it clinically, you'd say, it's barely noticeable. And this was the breast tissue, including there's usually some glandular tissue and some fat that we remove from the chest when we do this surgery. And in this case, it's usually in the range of 50 to 100 grams at most. The really larger breasts of older patients that have more fat, or they have been exposed to some estrogen that has increased their breast size. I try to make most of the time I'm using surgical excision of this tissue to allow me to have really good control over how much I'm removing. The really important thing I've learned in my practice is never excise so much that you get a concave shape at all. You have to still leave the chest wall convex and the skin convex, so you want to make sure you leave enough breast tissue behind, like a button of tissue behind the areola. To make the incision less obvious, I usually make something like a airplane-shaped incision. If someone has really large breast tissue and fat, and I'm taking it out, then I would actually remove an entire ellipse of skin in this area. And just to position the nipple properly, I would take it off and put it back on as a skin graft, like a nipple graft. So I would stick that back on. If there's not a whole lot, then I would just excise the skin on the bottom part. But usually that means that the nipple areola complex gets a little bit too low to give me a good cosmetic result. So in brief, those are the main things that I see on in terms of congenital issues. Obviously, I see a lot of other things that you see are overdevelopment, which is breast reductions, and then patients that have cancer, etc. But I have not tackled that in this situation because this is all we're not talking about reconstructive surgery. So, any questions?
Just a little point, Dr. Mukherjee.
Yes.
Would putting a silicone prosthesis subpectorally, infrequently we've seen there is some showing up of the prosthesis and extrusion at the lower outer quadrant. And as you very rightly said, that you split the pectoralis major muscle to avoid that complication. Another good technique is to take a lateral skin flap at around 5 o'clock position, laterally, just about 2.5 to 3 centimeter base and about 5 centimeter long, and deepithelize it and turn it inwards onto the lower outer aspect of the pectoralis major, thus actually reinforcing that the prosthesis stays where it has to stay and give a lower inferior cover, is a new innovation we thought is a very apt thing to do. I can't give you data of having done this, but certainly this has been published and some cases have been done this way.
So,
did I make myself clear?
Yes, I get it. So are you saying this in the situation of a patient who comes in with smaller breasts, is wanting a breast implant for
a breast implant? Yes. To give an additional cover of the on the inferior lateral aspect in a subpectoral prosthesis, silicone prosthesis.
Right. And the size of this dermal flap that you're rotating in there, what is the size of that flap?
It's about, the base is about, it's a straightforward rectangular flap. The base is about 2.5 to 3 centimeter. The length can be 5 centimeter, depending on the size of the woman and the size of the prosthesis, whether it's a 200 ml fill or a 300 ml fill, whatever you're going to do.
Okay. In sometimes, and again, when I'm seeing some of these patients, they're wanting about 500, 600 cc implants.
Yeah, I mean, in America, people are usually big, but I'm talking of young petite girls in India, 5 feet tall, who come with with primary ovarian failure. Another thing I would like to say, that the breast surgeon should look at primary ovarian failure. You should not simply focus at the breast and the non-development of the breast. There has to be certain treatment given and the ovulation should be tested. Many of these young girls have got hairy chest wall. A couple of my patients had pilonidal sinus in between the two breast in less developed breasts. So those are the things that come along with the congenital anomalies of the breast.
Is it something like PCOS?
It could be PCOS, but PCOS is not associated with the hypoplastic breast. Primary ovarian failure, where there is absolutely no ovulation, and the LH-FSH peak does not come at all.
Right.
It is an idiopathic condition, and in that case you get some hair on the chest wall.
Right. When you do this flap, do you end up with, because of the biggest issue in these patients, most of these patients, when they are getting their cosmetic breast augmentation, is their skin envelope is already tight, and we're trying to maximize it by putting in the largest, for them and their body size, a fairly large implant with a lot of stretch. So my query would be, when you do this flap,
the thoracoabdominal part of the skin? The thoracoabdominal part of the skin is pretty lax. Even in young ladies, the thoracoabdominal part of the skin is lax. It is always possible to harvest about a 3 centimeter broad skin flap lateral to the breast at 5 o'clock position in the inferior lateral position, and then undermine the skin both above and below in the thoracoabdominal area and close the defect primarily.
Okay. And again, in reconstructive cases out here, at least we use cadaver skin that has had all the cells removed from.
I know there are there are synthetic and cadaveric skins available. Yes.
Right. Obviously, for these patients, they are all self-paying for these cosmetic procedures. So the cost of that can sometimes be prohibitively high. You can end up by doubling or tripling the cost of the procedure. And so sometimes that might be a consideration why we can't do that. I do remember I had one patient who went up to a really huge, like I was trying to talk her down, and she already had 500 or 600 cc implants, and she now wanted 900 cc's. And she went ahead and got them, and
Was
then she had.
Was the cost of a silicone Verifill implant in US?
The company I use is a different one, but they're costing about $2,000 for a pair of implants.
Well, it costs you around 25,000 rupees in India, which is around, I would say, $40 to $50 is the cost in India of the best available $30-40. And it's a small GA putting it under the pectoralis. I'm very happy charging rupees 1 lakh, which is equivalent to $1,000 from the patient, and keep her in the hospital for 1 or 2 days in a small private ward. And the corporate hospital would charge around $3,000 because the cost of the prosthesis remains the same throughout India.
Okay, right. Yeah,
Thank you.
For me, I haven't really seen too much of rippling, even though some of our patients are really petite and they are thin. But when I used to put in the saline implants, which I still do for about 5 to 10% of my patients, I always try to overfill them so that they have less rippling on the surface. And with whatever materials they're using now for the shell, I see less rippling than I used to till in the last 5 years or so. They have done something to the shell to give less rippling, so it's not been as common a complaint of these patients. But obviously, also American patients have more subcutaneous fat in general, so it's less visible even if they did have some rippling. But it is a problem because they don't have any muscle on that lateral lower part of the breast. Anything else?
Yeah, we are joined by Professor Geeta Shetty as well as Miss Anjana Satpathy. They are colleagues from Northwest UK and Birmingham. So Geeta and Anjana, would you have any experience in managing these congenital breast disorders? How often do you see these problems? Would like to share your experience.
Sorry. Hello everyone. It's nice to be on this forum. Thank you, Professor Sharma, for inviting me, to this forum. Being breast surgeons, usually these patients do go to plastics, but we do often see in our clinics for non-development of the breast or hypoplastic breast or unilateral malformation of the breast, tuberous breast. So we do tend to see these kind of patients, and we do the differential augmentations when the patient develops a cancer on one side. So in those scenarios, we get involved rather than primary malformations of the breast. So in these kind of things, basically the patients, we are not looking into the cosmetic aspect here. We are trying to restore their previous appearance. So this, usually using the bigger implants is not in. We don't often see using the bigger implants. So whatever is the contralateral side, we are trying to match it to the other side. So in terms of rippling, yes, rippling is an issue, as Dr. Mukherjee said. It has been an issue, but we tend to avoid it with a fat grafting or putting a bigger implant, or even sometimes, reducing the skin by the mastopexy kind of thing. So that's how we tend to reduce these things. And now coming to the Dr. Sandeep, who was talking about, the lateral coverage. What, I was thinking, I tend to do a lot of chest wall perforator flaps, and the one of the things what we tend to raise is the lie caps, lateral intercostal or medial intercostal artery perforator flap. Maybe in these scenarios where you want a coverage, when you are having a doubt that there can be a wound dehiscence and endangering to an implant, then perhaps this procedure might be helpful, because we have salvaged implants with these procedures often. Again, my patients often are post-cancer patients, so I tend to salvage the implants if there is any flap necrosis because of, after the wide local excision or after the mastectomy. So if the tumor is very close to the skin, we tend to, obviously go quite bit more radical there. So in those cases, we tend to salvage the implants with these flaps. That's that's what I would offer in these cases. But again, as I said, mainly the malformation are, we tend less likely to see them. Usually the endocrinologist and the plastic surgeons, they tend to take over these cases. Thank you.
And sorry,
And
Dr.
do you have anything to say? Sorry.
Are you doing you're talking about immediate reconstruction right
Yes.
after the mastectomy,
Yes.
and you're putting in an implant?
Absolutely, right. Absolutely. That's the case, because I'm an oncoplastic breast surgeon, so tend to deal with the cancer along with the plastic side of thing as well. So I tend to do the breast reconstruction following the mastectomies, and also after wide local excision replacement therapy, with the chest wall perforator flap or LD flap. And if it is for the DF flap, then we tend to take a help of our plastic surgeons. That is the microvascular. That is completely different ball game. Yeah.
And talking about some of that skin necrosis, or
Yes.
do you do any kind of vascular study on the flaps intraoperatively?
We could do the vascular study. That is, the possibilities there. But often, with the pressure of the NHS and with the things, indocyanine green and the other methods where infrared technology, it is still not available on the ground at the moment. But there are some studies in the research form which are going in some places here.
Right.
Okay. Yeah.
Thank you very much. The discussion was really very interesting and enriching. So I request, because we have many questions pouring out from other participants, may I request Sanjay sir to we can complete his presentation first, and then we will.
I'm done with the slides, so I can take the questions, or we can open it up for discussion.
Thank you very much, sir. Thank you very much for this enriching presentation.
And I can actually put this presentation as a PDF and send it to you, so that you can share it with other people if you wanted to.
Great, sir.
That will be very helpful. Thank you, Dr. Sanjay Mukherjee, because I joined quite late. I'm sorry, because I tried to join, but there was a technical glitch. Thank you.
Now, for that, as a host, I would like to pay my regrets and regards to you, ma'am. Sorry for the inconvenience. And thank you for joining us, because we are in today's session, we are going to extract many information from all our experts, including you. So, sir, there is one question, very, very interesting questions that we have received. One of which is, doctor has not mentioned his name, but he has rightly asked, we talk about implants, especially the immediate reconstruction. So, how do we calculate the implant size? Like right now, we are talking about cosmetic augmentation. So, how do you calculate which size this particular patient should fit into? Because these are very costly, and in India, my personal experience, and Manish sir can also add into it, we don't have sizers. Like, we just cannot put it inside and say. I'm not sure, so you can better guide us regarding this.
Okay, so in terms of a cosmetic patient who's coming in for a breast augmentation, they have smaller breasts, smaller size breasts, and you really don't know what would keep them, what would make them happy. Firstly, when I'm talking to them in the consultation, I try to get an idea if they can bring in pictures or photographs of somebody else that they think that their breast size is what they would like to achieve. So that gives me a little bit of insight into what they want. I also, in the consultation, one of the biggest things I tell them is that the results are not predictable, because what you're putting in initially is in a tight skin envelope. their body frame might be different, their height might be different from the whatever their picture as an ideal. So there's a lot of almost psychological evaluation that has to go on to know what to try and get into their head and figure out what they want. And then obviously there's the unpredictability of the surgery, because you can size them perfectly, you put them in, and then the skin envelope does not relax a lot, or it relaxes a lot. That itself can change how much the breasts are going to project forward. So if someone has very inelastic skin, which sometimes you'll see in a reconstructive case, if they, let's say they had radiation or something, that breast does not look at all like a normal breast, just because the envelope is very tight and rigid. So the same thing applies in a smaller way in cosmetic patients. If they have very loose skin, for example, that they're never going to have a tight, perky breast unless you also do a breast lift at the same time. So they shouldn't have that expectation. So you kind of have to talk to them about their expectations for the surgery, as well as counsel them in case they need some additional surgeries like a breast lift or something to give them a more ideal shape. As far as, and again, you have to talk to them about symmetry and asymmetry, because that's also a big source of dissatisfaction post-operatively if they're not counseled about that, that again, you don't control, one side might relax more than the other. You might actually have to go back in and lower the capsule or tighten up the capsule on one side or the other. So I always try to talk to them about that during consultation, so that they don't get blindsided by that after the surgery. I also, the other thing to note with this is that the results change over time. So they're very, very tight initially, and the implants sit up very high. It takes about 2 to 3 months for everything to relax. So the shape changes a lot, the size changes a little bit. And it's not just the skin envelope, but there's actually some element of flattening down of the ribs by the pressure of the implant. So all of that makes a difference in the final size and shape of the breast. So they have to be informed not to make or rush to judgment on the results. And you shouldn't be rushing in and saying, "Oh, I put in the wrong thing." You could give it time to settle down too.
What I could get, most of this technique that we do in such patients, it requires lot of counseling, information, communication, as well as some trial and error based on some कि इसमें ये fit होगा, something like this, है ना, मतलब based on experience. Geeta ma'am has raised her hands, so I request ma'am to please ask her question.
It's not asking question. I just wanted to say we have to differentiate between the cosmetic augmentation and the breast reconstruction following mastectomy. It is very, very important, because the expectations are very different here. So in cosmetic, they got already the normal breast, or in malformation, yes, they will be grateful whatever we provide them. That is different. But in otherwise, the expectation is very high in cosmetic. In breast reconstruction following mastectomy after the cancer surgery is very different, and that you would be trying to match with an implant or a prosthesis with the normal breast, which is not finite. It is constantly changing with the body. Where you put an implant, it is infinite because it doesn't change much. Though the skin over the implant might go a little bit lax, that may cause rippling or folding of the skin, but the breast mound itself doesn't change. So that kind of expectation is very different. So in my view, in my last 12 years of consultant post, I've seen so many patients and coming back as well, and also before that in the registrar period. So in my view, the counseling is very, very important, and the expectations is much, much less with the cancer patients. And also, if we provide them a very high expectation, then you are kind of victim of your own success kind of things. Even with a tiny thing, the patient will come back to you, even though you might find it fine, like the patient might find something else is a fault. So that goalpost of changing the expectation has to be managed. But in the cancer patients, I always would say, yes, your other breast is going to change over a period of time. That may need a lift. that may need mastopexy or reduction mammoplasty, whatever. So that kind of a things we have to manage here. So that is something very different than the cosmetic operation.
Thank you very much, ma'am. Dr. Shivangi Saha would also wants to add something, or maybe she wants to ask a question. Yes, Dr. Shivangi, go ahead.
Good evening, ma'am. Good evening, everyone. It's very heartening to see all of my mentors here, Dr. Anurag sir, Dr. Manish sir, and Sanjay Mukherjee sir has also visited our department in the past as a visiting faculty. And it was
and received a book from you too. I remember that.
Yes. Thank you so much, sir. It was heartening to listen to you today. In patients with congenital breast asymmetries, wherever one side of a breast is normally developed, and most of the times, if it's a large breast, it would be ptotic. And when you put implant in the opposite side where the breast is underdeveloped, it would always be projecting forward, as against the other side, which would be more ptotic. If we do an upfront symmetrization, a lot of times we notice that even the breast where we put an implant, with time it undergoes certain amount of ptosis and it never exactly matches the normal one. So what do you think is an optimum time to do a symmetrization? And even after you've done it, because both the breasts don't sag equally with age. So how do you counsel patients regarding that? And what is your approach?
Well, the first thing for any patient that has any degree of asymmetry, and I'm doing different surgeries on them, even if let's, and I always tell them that if you're doing different surgeries on the breasts, your results are never going to, even if you make them perfectly symmetrical at one point, they're never going to be the same, because eventually over time, because the amount of ptosis that develops over time is going to be different from one side to the other. So they have to come in with this expectation that this is not like a once and done kind of procedure, that you are going to be coming back either to see me or to see somebody else to have revisions of this. Just like if you're doing a breast lift, you can't ever tell them that this lift is, you get a lift once and you're never going to need a lift again for the rest of your life. So it's the same principle, that time changes things, as well as the envelope. If the envelope has any difference from one, whether it's, like I said, whether it's had radiation, whether it's had any other breast surgery, whether there's a congenital issue, so that once the envelope is different, it's going to behave differently over time as well. So you'll have to keep making some slight adjustments. Hopefully they're slight ones, and it might just be taking out some excess skin where the skin is relaxed too much over time. So like a little revision breast lift. And I had one example, and the last picture shows some asymmetry when she finally came to see me. And so I had to do, I'd originally done a lift on the side that was a slightly bigger breast. And then when she came back to see me about 15 years later, you could see that, again, because she had a little bit more skin on that side, and the smaller side had very little skin, so it never really relaxed as much as the one that already had the breast lift. So I had to go back and revise the breast lift again to a little bit, but it was a much smaller revision that was needed. But you always have to again talk down their expectations of, it's not going to be one perfect result and you're going to have that for the rest of your life. If you are looking at yourself and you're dissatisfied with it, you should come in or see somebody, and the correction is usually not anything too drastic, but it'll need to be done.
Yeah, thank you very much, sir. So there is very interesting question, and I want the inputs from Manish sir, Geeta ma'am, and Sanjay sir regarding, because in aplastic or hypoplastic breast, there is always a problem with skin cover. So would you, and also as you said, we cannot just decide on in one setting which size we need to put. So what is the role of using tissue expanders in such case, especially like in oncoplastic surgery also, ma'am? You said you prefer doing immediate reconstruction, but most of the time we are worried about like capsular contracture because these are costly implants. So then we have to just do the capsulectomy and then put it again, something like. So what is your take or recommendation using tissue expander first, and based on the symmetrization we just do a second procedure and do silicone implantation? Yes, sir. One by one.
Okay. So my experience has been that if someone just has their muscle intact below the underneath the skin, I can put in a fairly decent size implant over there on that side, and without and I can do it through a fairly small incision. I don't know if you people use it out here, but I use a funnel that is a lubricated funnel. It's a Keller funnel, and you can go in through a fairly small incision, about 2. Like maybe 5 centimeters in size, to put in a fairly large implant. 600 cc implant can go in through an incision that size. So there's very little chance of an implant then getting extruded or being exposed. So I can put in, so you can get a fairly tight result without risking the implant being exposed in that condition. And you can generally do it right away. The only problem, especially if you're working with, let's say, tuberous breast or something, that you have to make those relaxing incisions on the inside, on the dermal aspect. I'm fairly aggressive, and I've been fortunate not to have too many issues with that. But otherwise, certainly you can use tissue expanders. But again, that has its own problems in terms of the patient having to have multiple visits to go through the process of expansion. It's an extra surgery. And so the implants themselves are not the biggest cost. It's just the number of surgeries that is more of a factor out here.
So this was the pre-pectoral implant that you put with the funnel, or just
I'm talking about subpectoral pocket, and so whether we put in the tissue. Now, obviously, in a patient that's having cancer surgery, maybe, and the muscle or cover is more compromised in that, or you've got thinner skin or thinner flaps, that might be more of an issue for those to really expand massively at the first time. But if it's a skin sparing mastectomy, then you have plenty of skin, and that's not a big issue.
Geeta ma'am would like to add, and after that, Manish sir, I need your comment.
Yeah, the implant, again, for the cosmetic, again, it is different. You got a breast tissue, some amount of breast tissue in front, in subpectoral expander kind of thing. In post-mastectomy or pre-pectoral breast reconstruction, I've stopped doing the subpectoral quite a while ago, actually. With the input of the ADM, we use quite often the ADM and use these implants. Now, coming to your question of expander, yes, we used to use the expander quite a lot. I must say. And then following radiotherapy, then we used to change it to the immediate implant. Again, the expander, what you're using, there are 2 types available here. I'm coming to the logistics now. I don't know about India. What are, see, the expander, which I used to use the Becker Mentor implant. So the Becker one is much more costlier in the permanent implant itself. Okay, it's around 800 pounds, and then the implant itself is around 450 pounds. So then we started to use the straightaway implant. Yes, if there is a capsular contracture, if they need again replacement of the implant, which only small percentage would go for radiotherapy and capsular contracture, then we can replace the implant at the future date. That would be the concept of that. Yes, rightly, Dr. Mukherjee said that the flap is an issue. Skin flap is an issue. See, the only way you can do the decent pre-pectoral implant is first to look after the skin flaps. There is no doubt in that. Okay, even if you put the ADM, it is not going to replace for the best of the skin flaps when you do the dissection. There is no compromise in it. Now, you got enough skin flap after the mastectomy to match with the other breast. Yes, in some of the big breast, if the woman needs, for example, E, F, G cup size breast, where I can't put the 900 or, like 800, 700 cc implants straight away just underneath the skin and the ADM. ADM itself can, accommodate 600 cc, if you think about Stratus or Braxton, whatever the brand you use, So, and also it is not safe for the skin flap either, for the wounds. So we tend to maximize how much we can use. I have stretched up to 570 cc straight away implants. Yes, if the patient were to need the bigger implant, yes, expander is the role where we can put the expander and slowly expand it once the wounds are healed up. And then you can put a permanent implant. Only in that situation, I can think of an expander. And some of the expanders, when you put, there can be an artifact when they go into an MRI. So that's something which you need to keep in mind. If the patient were to need CT scan or MRI scan in future for any metastasis, for suspected anything, so then the MRI, especially because of the metal being there, then the radiologist will come back and say that she's not suitable for MRI. So something which you have to keep in mind when you're using an expander. That's
Thank you very much. So, Manish, sir, I request if you can just talk about the cosmetic. First of all, in AIMS, it's a very high volume center, and the cost relatively is much less compared to any private setup. So, your experience, how many patients really come and turn up, all the leads turn up into augmentation for cosmetic reason? What is the approximate cost there? And how do you calculate the size? Because you are based in India, so you know more about the Indian patients, Indian context, because most of our participants from India only. So they would like to know from you, how do you manage them? How do you calculate the size? And how do you further, how do you counsel them? Can you please tell your experience, sir?
Yeah, so I will very briefly tell. So it's a struggle everywhere because people who come to government setups have their own mindset. The cost is a challenge for them also because cost is not very less. It is something which they don't expect when they come here. So definitely they have to be counseled. They have to be told that this component is not sponsored by the government, and we see a lot of resistance from government schemes to sponsor any type of breast implants. So cost is the issue even with our patients, but still, if we properly counsel them, most of them will agree if they are really in a problem. And now the size calculation, I think we are talking about the size calculation of the implant, which is very true. But ultimately for us, the most important is the size of the other breast. So we use a breast tree software. I think you are aware of that. If in case you are, in case somebody is not aware, I can ask Shivangi to have a projection. If you can share some screen rights to her, she can project. So I just so what we do is we use this particular software very frequently. I think Shivangi, you can use some values and tell them exactly what do we do.
Let's look very interesting, and I hope
Yes. We calculated.
would like to
We use
understand.
this particular software very frequently,
Yeah.
and this is very good to calculate the size of the opposite breast. Now, Shivangi will just explain. I'll just tell you very simply. So when we use a flap, we use centimeter thickness around 3 centimeter thickness, and we see the dimension of the flap, and we calculate the flap size according to that. Of course, it depends upon that how much primary closure is available. And when we calculate the implant, so this is the size of the other breast. Now, of course, the size will depend upon the pocket which we create. So we have to understand that this is the size of the breast. So Shivangi, can you just quickly tell exactly?
Yeah. So for this particular software, we need just three measurements. First is the sternal notch to nipple distance. Second is the fold projection to inframammary distance. Fold projection is when you project the inframammary fold onto the anterior surface of breast. And from there, you measure the inframammary distance, which is F to FP. And the third one is nipple to the inframammary fold distance, NF. So let's say in a particular woman, if the sternal notch to nipple distance is about 21 centimeter and the fold projection to IMF, let's say it's about 11 centimeter, and nipple to IMF distance is about 9 centimeter. And if we try to calculate the volume, it gives a volume of about 356 cc. So based on that, if we are performing an implant-based reconstruction or a flap-based reconstruction, we would be able to know what is a ballpark volume of implant or autologous tissue that we may need to reconstruct that particular size of breast.
So Shivangi, you can give an example of DIAP or LD, that in case we use the LD, then what implant extra we will require, and DIAP, how do calculate size. So maybe example of LD you can take and tell people that
For
in
LD, sir, like with this particular software, we can also calculate the volume of LD based on the patient's BMI and the skin paddle width. And if we know that LD is able to provide a certain amount of volume, let's say it's about 150 cc of volume for that particular woman, then the rest of it can be
200 cc we can augment by the implant.
augment using a
It is
flap.
just a ballpark figure.
Yes, yes. And for the implant, apart from the volume, there are some other parameters that are important, like the base width and the projection of the implant. So to decide the base width, again, we measure the medial and lateral extent of the breast. This is the medial footprint. This is the lateral footprint. In between the two, we measure how much is the base width, and we subtract the pinch thickness of the flap from that particular area so that we know what is going to be the base width of the implant.
I have a question.
Yes, sir.
What if this patient has brestosis on the uninvolved side, and you're going to do you normally do a breast lift at the same time as the reconstruction?
So that Shivangi already asked you, sir, because we prefer to do at the same time, but we definitely counsel that the results are going to change. So this is a rough calculator because there is no way to calculate volume. So this is a rough calculator to just tell us that what volume patient has. And then patient also very realistic expectation. Once we tell the formula, then patient also knows, yes, my size is this. So it helps in very much as in counseling with patient. That is what we feel, and we find it very useful.
Sorry, my question was that if you are doing a breast lift, then these numbers are going to be changing, correct? The nipples, supraclavicular notch distance, etc. So, and you don't take those. I'm presuming you're taking these measurements preoperatively.
Preoperatively, sir. In our patients, sir, they don't opt for an immediate symmetrization of the opposite side. We've never had to do it as of now. And I'm sure in such a scenario, it would become more challenging because then we would have to take the projected symmetrized parameter.
At that time, yes.
Yes.
Right.
Yeah.
So that we can. So I hope Dr. Sudhi is very useful for you, because this is how.
So this is something very, very useful, and something it really added to the value of today's presentation. Thank you very much, sir, and Dr. Shivangi for sharing this information. And I hope it is really beneficial for other participants also. Though we have many questions, but because implant is a very interesting topic for most of us. So a quick comment from once I put in an implant in one of the patients, and when I just read the literature, and I was very much shocked because in literature there was one disclaimer that it can cause cancer. It can cause cancer. So I was really shaken aback. How should I counsel patient about this? And I think this was with micro textured implant, but still in that implant also they have written. So a quick comment from all the oncoplastic and plastic surgeons regarding this. How do you counsel the patients regarding this? And how do you do that? And is it really that harmful? Because once it is done, it is for lifelong, I think.
So so we have a very standard method of counseling people. I think you can tell that we are at a public sector, so people usually the counseling may be little different, but we have very standard way of counseling that we tell complications which we expect to happen. There are complications which we don't expect to happen, but they are documented. So that becomes very easier for us to communicate with patients that we don't expect this complication at all, but it has happened once. We don't expect it, but still we have to tell you because it is part of the documentation process. So that helps us in talking to patients little better way. This is how we do it in our practice. Right. But we have to tell, there is no option.
Okay, because what I am talking today is with the stalwarts of plastic and oncoplastic surgeon who have a very long duration of experience of putting implants. So you can tell us in a better way, is it really that harmful? Should be skeptical about it, or should be free in offering implant-based reconstruction in such patients?
I think we have done quite a literature review on this, and I am not sure about the numbers today, but we did, I think, 2-3 years back, Shivangi. I think we have not more than 2 to 3 cases which actually tell that it is because of the implant. There may be some anecdotal reports. Shivangi, do you have the latest number
So
on
the
hand?
breast implant associated ALCL is a type of cancer which can happen after microtextured breast implants, but it's extremely rare. I think the current incidence is about 32 per 10,000 patients in the world, which is much rarer than a breast cancer. So often, when I have to counsel a patient regarding the risk of implant associated cancer, I tell them that, just having breast gives the risk of having breast cancer, which is far more commoner than having cancer with an implant. So there is a risk, there is a possible risk, and most of the times that kind of cancer is curable, like removing the implant, excising the capsule can help in early stages. So if they are willing to take that amount of risk, then we go ahead with the augmentation.
Great. Thank you very much. So Geeta ma'am would like to add. Yeah, thank you, ma'am.
There has been a long debate in Western countries because they've been seeing these implant-based complication for last 30, 40 years since it has been pretty much introduction. I'm sure, pretty much there has been a lot of literature on it. And yes, at one point they claim the textured implants are the one, as which is causing the ALCL. But again, as Shivangi said, then it is pretty rare thing. But we do counsel. Obviously here we have a duty of candor. We have to tell them that this can cause a cancer. But again, as Shivangi said, like it is a rare phenomena, and it is not a common phenomena. So the literature varies from 1 in 9,000 to 1 in 30,000, to be honest. So in the literature what we have in UK, we tend to counsel to 1 in 30,000 may develop in ALCL. Yes, often it can be cured just by taking an implant, provided it is identified at the early stage most of the time. Okay, so it is an anaplastic large cell lymphoma, and we have a duty to report it to the nationally as well. So yes, there is an definitive associated cancer associated with this implant reconstruction. But again, the amount of implants what we do, if you see, then the likelihood of this happening in those women is very, very less. You can put it like that.
Thank you, ma'am. Thank you very much. Sanjay sir would like to add. So, has anyone seen this?
Yeah, just from the to show the uniqueness of America, they obviously putting in implants is fairly big financially. Even if it's for insurance, the patients still have to bear quite a bit of the charge. Obviously, all the textured implants have been taken off the market. I'm not sure what the status is in India, but you can't even get them anymore. You're just putting in the smooth implants. But there's become a market created by plastic surgeons out here for the end block. They call it the end block removal of the capsule. So they've almost created a lot of marketing and a lot of patient awareness, even more than normal for this, because it's a marketing and business opportunity for some plastic surgeons. So they're specializing their entire practice on going into these patients that have some of these textured implants, especially in cosmetic patients, and saying that they're going to remove the implant and the entire capsule and then with an end block dissection. Because a lot of these patients are, it's a reasonable worry to have that, am I getting some cancer because, any increased risk, and if you can, they're not very savvy in terms of the rarity and the lesser numbers, but then they present with this and it's built up into this extraordinary surgery that costs about 10 times as much as the breast augmentation itself would cost. So that's the business side of things out here for cosmetic surgery.
Yeah. So I just want to understand, has any one of you seen any patient with ALCL in their
No.
career? No. So it is most, because if high volume surgeons like you have no, so we surgeons must not be that much worried about, at least. Sir, there are a few other questions related to implant, then we will switch the discussion. One is that FDA approved. So the ones that are available in India, mostly they are not FDA approved. I'm not sure how important is this FDA approval is, and should we consider putting only FDA approved, or like we can put any implant? We have here Motiva, which cost around 40,000. So to the patient, but that is not FDA approved. So what is your take? Like, what are the implants there you use?
Out here, Allergan is the main one. They have a massive share of the market with FDA approval. I think the biggest reason is that they are actually collecting data on implant leakage. So there's a breast implant registry, and so every implant that you're putting in is going into that national registry, and they're tracking them with the numbers. They provide a lifetime guarantee, or the warranty is for a lifetime, and they provide so long as it's a spontaneous rupture, they will provide the patient with a free implant and money towards getting that implant removed and replaced for the lifetime of the implant.
Lifetime of the patient, or so lifetime of the implant? Like, I think lifetime of the patient.
Of the patient, correct.
Okay, patient. Okay.
Yeah,
But
and that's for silicone. The saline ones only have, I think, maybe like a 12-year warranty. So after 12 years, if they leak, then they have to pay for it themselves. But the silicone ones, for sure, they're providing that kind of thing, and that might be part of the reason why they're more expensive out here. But they're also collecting more data so that they can reassure the patient that the leak rates are lower, the complication rates are lower, etc. So,
Manisha, would you like to tell what's the status in India? Do we have certain registries like what Sir said, and do we have some coverage like this? And which company do usually you use in AIMS? What company would you like to recommend? Because there are many surgeons, in fact, plastic surgeons from different areas, from government and private sectors. Like to know more about it.
So we use Motiva just because we easy for us to get, because sometimes there are a lot of I think in last 3-4 years back there was a lot of issue of implants. Lot of people got deregistered. Finally, we got hands on one of the. I think it is a fairly good implant which we use. I am not recommending anyone. This is what we use usually, so that we usually for us, the major challenge, unlike people from US and UK, is they don't have an inventory of implants. So we want somebody who has an entire inventory, because sometimes you get connected to someone who doesn't have a size with what you want, and usually it takes 3 to 4 weeks to ship. So we use Motiva, and I am not aware of any registry, but of course our discharge slip has the sticker of the company and other things, and I'm sure whenever in case any patient complaints or anything comes back, we are going to inform the company, but we don't have any registry as such. I'm not aware of that.
Right, sir. Thank you. And well, I think you all give very good antibiotic coverage from pre-operatively to post-operatively. Do you?
May I ask a question?
Yes,
Do
ma'am.
you have anything equivalent to FDA approval in India? How do you select an implant which is safe to use in India? Do you have anything like that? How do you get this implant on the market?
Manish sir may answer this.
So we don't have anything equivalent to FDA, but even if anything is FDA approved, you cannot market in India till the DCGI approves it.
Yeah, so DCGI is the one which approves anything.
Even if it is FDA approved, you cannot market in India directly.
No, that's why I'm asking this question, because we use Motiva in UK. We do use Motiva. We use Eurosilicon and Mentor. Allergan were stopped, after a few what is it, a year or 2 years ago. So I just wondered, like what do we have in India, that equivalent way of dealing with this kind of situation? And I also wanted to just comment, if you're talking about oncoplastic breast reconstruction, somebody should not forget the dermal flap when you have a big breast. I just wanted, I don't know, I didn't find the, context when we were talking, when I can get this thing into the discussion. It is because I think the Asian women, especially the Indian women, have quite high volume of breast tissue and with a high cup size. So you can use the dermal flap even without ADM, just for prepectoral, something which, can be useful tool with you guys. Thank you.
Yeah, certainly, because majority of the patient, even if they desire reconstruction, they cannot afford ADM. So we have to look into the affordability of the patient. So very quick comment from cosmetic surgeons and oncoplastic surgeons. Suppose if someone wants to put an implant into any patient, which implant to choose? Smooth, textured or micro textured? Also, which implant to choose? Anatomical versus round implants? One by one, please. So maybe Sanjay sir can start, and then
Yeah, you can
Yeah.
start.
So as I was expressing, the textured implants are not available, whether for reconstruction or for cosmetics. So the only ones that are available now are the smooth round implants. The one of the benefits is that it moves around a little freely, and you don't develop any asymmetry. Whereas with those textured implants, if they rotated either a few degrees or 90 or 180 degrees, you got the shape of the breast would change completely. And it also sits more rigidly because the tissues get attached to the textured surface. So right now, all that we have over here are the smooth implants, which again, being completely round, if it rotates at all, you don't get any asymmetry in the appearance.
Right. So thank you. So Manish sir, do you agree with this statement, or would you like to add something?
No, we definitely agree. Actually, again, I told that we have a strong issue of inventory most of the time. So most of the time, the inventory is the issue. We use definitely Motiva and Sebin both. So we usually choose anything of that size which is available. We are not very specific on many things. But anatomical implant, we have not got across those implants. So I personally don't have any experience. I can ask Shivangi if she has used any of them. Shivangi?
Sir, Motiva Ergonomics is a recent generation of Motiva, which is an anatomical implant. More than anatomical, it's like a shape. It's a softer gel which changes shape when the patient is erect. So the lower pole has more volume compared to the upper pole. Upper pole, it is a more fluidy silicone implant. So although it's not anatomically shaped, it's round shaped, but it gives a more natural feel. That's the idea. But we've not used anatomical implants on our patients.
That's for sure. Yes, ma'am. Geeta, ma'am.
It is a different for cosmetic and again reconstruction. In reconstruction, you are looking at after mastectomy pear shape, breast. If you put around, it will be looking, it looks like some round mound just underneath the skin, which doesn't have a flow from the clavicle to the breast, mound. So we tend to use anatomical shape almost all of the time, except in some cases when they come up with the rotation 2-3 times. Some patients, they just, the implants get rotated, once. Okay, still you can tighten the lateral pocket and the medial pocket and make sure that it doesn't rotate. But again, if there's a 2 times rotation, then I tend to go for the round implant, where I don't have a choice there. But in oncoplastic cases following the mastectomy, I tend to use the anatomical shape implant. And most of my colleagues here, they do use the anatomical shape implant. And again, between textured and smooth, I was off for a few months, but until then, we were using textured implants. Even now as well, the Mentor is the one which we tend to use. and the smooth is very less, because I don't know, maybe because we don't have much experience, and as Dr. Mukherjee is saying, once it is completely stopped, then we don't have a choice. That may be the reason. And yes, Motiva certainly has come up with the another anatomical shape implants as well, I guess. And yeah, for the breast reconstruction, total breast reconstruction is completely different ball game than the cosmetic operations, honestly.
Right. Thank you. Thank you very much, ma'am. So, sir, once you said that you used saline implants in few of your patients. So, can you please tell what was the, are the saline implants completely out from the game, or we still use in some patient in which conditions?
Certainly, some patients' cost is a factor. So it reduces the cost of the surgery by about $1,000 because they're much cheaper. Some patients have concern about not being able to detect a leak with the silicone gel, because the volume, the shape might change if it's leaked, but it usually sits in that same within the capsule and occupies the same volume. So they have a hard time, and even clinically, you have a hard time knowing if a silicone gel implant is leaked, and they actually recommend doing an MRI, which itself is fairly expensive, and their official recommendations are to do an MRI every 3 years or so. Almost no one gets it that often, but that's the official recommendation. So the cost is definitely a factor. The reason to choose silicone is that it feels much more natural compared to the saline implants. Like I was talking earlier with the funnel, the size of the incision has become pretty similar. But earlier, the incision size for a silicone implant used to be much bigger, and that was one of the advantages, that they would get a much smaller incision. Or you could do a circumareolar incision for a less visible scar. So those are the reasons to still choose saline sometimes. But now, like I expressed, about 95% of my patients are definitely choosing silicone gel, and only the ones that have a price constraint or worries about leakage, they're the ones that are choosing the saline implants.
Yes, sir. I'm a bit surprised when being in USA, if you talk about cost constraint, because in India we often feel that those in Western countries, these implants and other things, people don't have any. I'm not sure, but I'm a bit surprised to listen that there are cost constraint with the people. So
Right. I think the only difference the difference probably is that in India they're probably saving up their money to bring it in for a breast augment. Over here they're applying for a new credit card or credit to get the cosmetic surgery, and sometimes their credit is not good enough to even borrow all the way up. So there's not that much financial. So some people definitely have very limited financial resources out here too, and surgeries are more expensive here compared to in India.
Yeah, exactly. So now we are at the end of our session conclusion. So there are a few important quick questions. First of all, sir, one of our participants, Dr. Moksha has asked if you could provide us, and many other participants has also requested, if we can get some surgical videos of yours, if it is available, so that they have something in their mind, how should they approach with their patients?
Of procedures?
A surgical procedure like nipple retraction or this
Sure.
excision, how you exactly do it, something like a bit of exposure to them, so that some new surgeons or someone who wants to really upskill.
Yeah, for training purpose, Sanjay.
Sure.
Training purpose, sir. So these surgical videos will help them a lot regarding improving themselves. Secondly, sir, there are breast surgeons in India who are keen to upskill, because most of the time they are surgeons, general surgeons with a special interest in breast surgery. So they are keen to learn more about cosmetic corrections also. They just want to manage all sort of breast disorders, including the congenital breast disorders as well. So is there any training program for general surgeon, not the plastic exclusively, but for general surgeon, through which they can get some fellowship or experience?
Yeah. I know Geeta has organized many courses in the past, but they are mainly post mastectomy reconstruction. But there's no reason why the courses like that, when different surgeons with the skills can really not join their hands and help the next generation to become better. I don't know. I know Geeta has conducted these courses at many places. Maybe Geeta and Sanjay, would you like to discuss about the future, just in case the way you can really train others, sharing your experience?
I think when more and more people are trained into this or exposed to this, I think it will help create more awareness regarding management of such disorder. As already said, these patients are there in our society, but most of the time either they don't find right doctor, or because of cosmetic concerns they just suppress their concerns. So if we have more and more doctors, but I'm not sure. I just want to understand: is there any training program for breast surgeons also to upskill themselves in cosmetic surgery as well as in oncoplastic surgery?
Right. Go ahead, Dr. Geeta.
Thank you. In oncoplastic surgery, we have as Professor Sharma said, I think 4 years ago, I did a live course in AIMS for chest wall perforator flap. After that, it took out in a big scale in India. And after 1.5 years, I used to hear from different centers, including Tata, including Kolkata, everywhere. They have done 100 to 150. So yes, these, there is a way how they can learn, and there are, through the courses, and I've had fellows, quite a few fellows from India, from Chandigarh, from Mangalore, and from everywhere. They have spent with me 2 to 3 years, and they have gone back and they've started their, even breast MCH as well in their institutes. So there are ways how they can do these things. And also, I think now the India is much better situated compared to 4 to 5 years ago, when it was very naive in breast oncoplastic, especially. But the address where we need to address it is not just a metropolitan for few surgeons. It has to be addressed at the grassroots level. That is where it is needed. So even simple breast courses, with a simple breast disease management to the grassroots level, like MS and DNB students, if they understand how to manage these patients and when to refer these patients to the more specialized breast surgery, that is what is needed. I think many of the surgeons who are more interested in the breast, they all know the roots. I'm sure I can vouch on it, because I've been liaising with many other surgeons in India on this matter. So they know the route. There are ISTP route, there are fellows route, there are MCH route, and obviously they can come through the PLAB. That is a completely different route, but I'm just talking about the fellows route here. And there are a lot of courses has been happening even through ABS, as well as, personally I've been conducting lots of courses as well. There are ways, which can be, that is a completely different topic. We can have a presentation on it, how the ways. That is completely different. Absolutely.
It is not difficult at all. Besides ACC, we do conduct a lot of surgical courses in vascular surgery, of course, unrelated to this. But all I am saying is that there are many, it is not difficult to organize this. One can pair it up with you.
If I specifically ask, is there any, do you provide any fellowship program in UK? And if yes, how any participant who is interested can connect with you?
There are ways, I think we have given the lectures quite of many various places, even in ABSI as well. I think we have done this 3-4 times. Shankar has done it, my other colleague who has been often there, and I have done it, how to approach for the fellowships and for the training in UK. That is mainly we are coming from the oncoplastic side. It is not the cosmetic side, I must confess. Okay, we do lots of cancers, lots of cancer surgeries and reconstruction and contralateral symmetrization. That is what we tend to do. And this is completely coming from oncoplastic side, not from the cosmetic side. happy to help you guys. If you have a next presentation, happy to show you what are the routes, the way they can come in and then have their exposure to the oncoplastic breast surgery. There are so many observerships has been conducted as well, not only observership, even fellowships, 2 to 3 years. There are ways. Yeah.
I request, ma'am, if you can share the details so anyone interested can find those details and can connect with you maybe later on. In WhatsApp group, you please share if you can, right? So
Okay.
okay, fine. May I request Sanjay sir, Mukherjee sir, it's regarding cosmetic. Do we have any program through which a general surgeon with a keen interest in plastic surgery, but not has done plastic surgery, like for breast surgery, we have courses. So is there any ways through which that surgeon can excel oneself in plastic surgical procedures, especially in breast?
Well, after I can give you my experience. When I did my fellowship out here, it was a 2-year fellowship after doing general surgery out here. I did it in India. I also did repeated general surgery out here, which was about 5 or 6 years, and then did a plastic surgery fellowship, which was 2 years. The cosmetic side of plastic surgery was mainly kept away from the residents and the fellows. We didn't have really good training on the cosmetic side. So we learned a lot of reconstructive surgery, trauma, that kind of stuff. But so when I went into practice, I had to develop all my skills. Even though I knew the theory of cosmetic surgery, but I had to work out it was work out cosmetic surgery by myself in a solo practice. And the toughest part about that is the judgment calls. Just like you had plenty of questions about the size of the implants and how to counsel the patient, tempering their expectations. Because again, when they're undergoing cosmetic surgery, their expectations are sky high. And if you still want to have them undergo the surgery, but you don't want them to have such high expectations that they're going to be disappointed by the final result. And unfortunately, that comes with spending enough time doing these procedures and seeing enough patients so that you learn from I'm sure my initial experience for the first years, I probably had patients that I didn't know how to counsel properly, etc. So it's hard to teach that judgment call, and again, decide which patient is so crazy that you'd never want to touch them, and then to find that out preoperatively.
Right.
That's something that you learn with experience. But I think as far as the actual, when you're in the operating room, what are the things to do? What makes your life easier? Where the pitfalls are, that kind of stuff, and then the things I've done over the years to refine the procedure, make it more efficient, etc. So I can definitely put some things together for that. But the judgment calls are something that will have to be developed by figuring out what the patient wants, needs, and what you can fulfill. The smaller procedures, like we're talking about, for example, the inverted nipple correction, etc. Yeah, little small videos about that or something can make it. It's relatively easy to do. You're not going to leave. The patient's not going to be. It's not super expensive or something. So that's certainly something that I can put together. I also put together the presentation. I have put it on your WhatsApp, so you can share it with the group.
Sure, sir. Thank you very much, sir. And one last comment from Manish, sir, regarding because you head the department from one of the premium institutes of the country, and sir, any possibility, any breast surgeon with a special interest in breast surgeries, including everything, oncoplasty and plastic, is there any scope or provision through any means through which they can upskill themselves in this cosmetic surgery part?
I don't know any formal way of doing it because AIMS does not allow anybody in practice to come to train with us. But I'm sure that if we do some courses specifically meant for breast surgeons, I think that is the easier method to do it. Currently, we are focusing more on other plastic surgery aspects. For example, we will usually teach a lot of liposuction to people and lipofilling to people, but not in the breast setting. We will teach them in setting of facial surgery also. So we are We are not like other breast surgeons who are focusing totally on breast, but we do a lot of cosmetic procedures which are applicable to breast also. So, we regularly do conduct courses for our own people in the department, but I don't know how useful it is for you. That is mainly for to upskill ourselves. Next month, Dr. Srinivas and Dr. Bhagwat Mathur are visiting our department for 3 days each, and they'll be doing some surgeries. But that is mainly we do mainly for our people, because we have a 35 people department. So usually we do like that. So if there is any opportunity, I will definitely put in the group.
Thank you very much. And
Can I make a suggestion there, Sudhi? The good thing about the problems which you have discussed are these can wait. I know they are distressing to these young women. So one way could be that as a whole group can really pool some cases together, and whenever colleagues like Sanjay Mukherjee or Geeta or Anjana or others who are really good at it, they are visiting, they can just demonstrate and people can learn. There is one simple way of doing it.
Right, sir. Sir, otherwise, through this forum, I would certainly request, especially Manish, sir, because he is more approachable, that if he can just like I'm an endocrine surgeon also. So, what we do in our endocrine surgery, we know we are MCH, but still we conduct courses to upskill general surgeons also regarding, so that more and more awareness regarding endocrine surgery it spreads. No, we just not as a competition, but as a spreading awareness and knowledge. A request through this forum maybe that if you can consider all the surgeons with a special interest in, just give them some insight, so that anyhow, if they are trying to do either alone or with some plastic surgeons, they have a good knowledge about what these procedures are about. Maybe when more and more good results they come into the public, more and more awareness may be created regarding these procedures, maybe. Yeah. And
Definitely.
yeah. So
And we can post some results regularly in the group,
yes, sir.
whatever procedures we do. And I think we can maybe as a forum, or we can discuss. I think one-to-one discussion is always possible. I think that is a better idea, to have a case and do a small discussion. So
Yes.
that is always possible. And I am already in the group. I have been added yesterday only.
Yeah.
So we'll be happy. And one more thing, I think we are shooting the time also. Just to give you a different dimension of care, we do a lot of transgender breast surgeries also. That is the breast reduction and augmentation for transgender people. And I think we are one of the largest number in the government setup. So that is also something which we do. And it has a very different set of challenges, right from calculations, right from marking them from memory crease. So I think that also is something which we do very frequently, just to give a mention to you, so that people are aware that we are doing that also. That is, we do that in equal number as other breast conditions.
Yes, sir. Yes, sir. Thank you very much for your mention. The thing is, there is echo. Yeah. So thank you very much for your mention. So just to mention, there are breast surgeons who are really crazy about doing all sort of breast surgeries. So, request for just keeping a room for them. So now before, and I'm extremely happy for today's session. It was really, really fantastic session. And now that since that now time is up, that we have to conclude this session. And before I conclude, first of all, I would like to welcome my teacher, Dr. Gyanchand. Thank you, sir, for joining us. He's from senior professor from Department of Breast and Endocrine Surgery, SGPJMS Lucknow. And thank you, sir, for joining. And very quick comment from all our faculties, Sanjay sir, Manish sir, Geeta ma'am, Gyanchand sir, Ajay sir, regarding this forum. And I request everyone to please switch on their camera so that we have a good selfie, which our team would like to project on various forums as a memoir. And
I can say it is easier to click Sanjay Mukherjee now because sun is rising in California now.
Yes.
It was difficult. I could recognize him only by his voice an hour ago, but then he says that sun is rising there.
Well, maybe next time I'll be in Hawaii and I'll be further away.
And the other thing is that as Sudhi says that, not Sudhi, Manish Singhal says that they're really offering this surgery to transgenders, very good. But now the hands of Sanjay Mukherjee might be tied because only two genders are recognized in USA.
Yeah, but even two, you can go back and swap between the two. and actually, I have done some transgender too out here. But I think it's going to become
California,
definitely
sir. He's in California. He's not particularly in the US. So it makes a lot of difference in California, I suppose.
Yeah.
They little differently. Yeah.
Yes, sir. So, very quick comment from our chief, our guest speaker, Dr. Sanjay Mukherjee, sir, about our forum. It will be motivating for our team.
Well, I think this is really wonderful. It's I think it's great that people are so eager to get information, and it does fulfill certain things that are beneficial to me as well. If all this whatever experience I've had in all these years, I haven't initially I was in a teaching position, but haven't been. So it's very good to be exchanging information, and it's great to see the progress that India has made. Just sheer numbers and the number of institutions and physicians. Because obviously I left about 30 years ago, almost 89. So yeah, 25 years ago. So there's been so much changes and so much progress, and I was so happy when I went to meet Dr. Singhal and see what a big center has opened up out there for plastic surgery. We had nothing like that when I graduated. So
thank you. So
it's good to see that the progress is ongoing even now.
Thank you, sir. Manish sir would like to say something for our team.
No, thank you. All the best. And you are doing excellent work. You are taking everything to grassroots level. Your effort is commendable, and we are with you, and keep it up.
Thank you very much, sir.
I felt very nice to join today's session with you. Thank you very much.
It was really very interesting and very informative being with you all today. Thank you very much. Ajay sir, would you like to add something, sir?
Yeah, it is really very exciting. Even though my main job is transplant surgeon, but about 10% of my work is endocrine. I do breast surgery only when I go to Jan Swasthya Sahyog in central India, where in my sort of a supportive role when I relieve Raman Kantaria. So one day we'll see Sanjay Mukherjee there as well, to the other extreme, other part. And any one of you would be most welcome. So lovely to see Professor Gyanchand, amazing surgeon, and what he trained. I could really see the reflection of it when I went to Meerut to see Sudhi doing minimally invasive thyroid surgery. I could not believe it. It is not for me to do. I'll still be happy to do by open technique, but it was amazing to see that Gyanchand's training is working very well.
Thank you, sir.
Thank you, sir. Geeta ma'am, would you like to say something for our team? I'm extremely sorry again for the inconvenience that you had, but thank you very much that you joined. You considered us, you joined, and it's really very.
Geeta's contribution to in training in India is just unparalleled. Not just in breast surgery and general surgery, and also in perioperative care through ACC. She is astounding, my God.
Yeah, it wouldn't have been possible without Professor Ajay Sharma. I must say that, he's my mentor. Right. Okay. Yes, knowing what to do, when to do is very important. And also when not to do is also very, very important. So it is just having the basic foundation is very important to climb on, what we want to do. But having a mentor and having the proper training is the utmost, and it cannot be replaced with any of I know conferences, symposiums are very good, but the training, what is necessary for any surgery from the mentor is the important. I know videos are very good, and then once we, live demonstrations are good, but once you have the foundation, then you can pick it up. But initially, I would say the mentorship is very important, and the training is important. And there are means, how you can approach to those. So you just need to know, and they have been there. We have already done many presentations through ABSI UK, ABSI in India, and also Epsicon, isn't it? Is it Epsicon? Yes, it's Epsicon, and also done the many courses and also trying to take it to the grassroots level. There are ways, so please find out and then get the proper training before embarking onto this journey of surgery, oncoplastic breast surgery. And also, it's more important for the cosmetic breast surgery because they are normal patients and they are coming out with much more different expectation.
Right, you are absolutely right, ma'am. And this forum, we just cannot wind up without comment from my mentor and guide, Dr. Gyanchand. And to introduce who is new to him, he is a cosmetic thyroid surgeon. So, like, he removes the thyroid without putting any incision in the neck cosmetically. Even big thyroids, he is very trained in North India. He has his own name. And a quick comment from sir. Sir, would you like to say something for our team, their efforts?
Yeah, thank you very much, Dr. Sudhi, and I have listened the entire presentation and especially the discussion, which was very informative and very useful for everyone. That how to plan and for all the flaps and how to get training, how to start, how to choose the patients and everything. So excellent talk and excellent presentation, and it was a good session for everyone. And thank you for every speakers and every presenter for this session, and thank you very much for inviting me on this occasion. Thank you.
जल्दी से ले लो. Thank you very much. And since we are just on time, and now it's time to conclude this very interesting session that we had. And for those who practice endocrine surgery, there are a couple of information. First of all our meetings are recorded because these are our very precious very precious information that we exchange. So all the meetings are recorded. This meeting also is recorded and will be uploaded on YouTube. The link will be shared soon. So please stay connected. For those who practice endocrine surgery, the next month is an odd month, that is March. Though we are a bit late, that this is a February meet. Now March meet will be pending, and we are having a very interesting endocrine related topic. So please stay connected with us. The details will be shared soon. And with this, I request, I thanks once again all my faculties, Dr. Sanjay Mukherjee sir, Dr. Ajay Sharma sir. Sir, without your support, this meeting would not have been possible. Thank you very much, sir. Once again, Geeta Shetty ma'am for being with us tonight, Manish Singhal sir for sparing up his precious time, Gyanchand sir for being with us, Sandeep sir, though he has some work, so he has left. Sandeep Kansal sir, he was also there with us. Anurag Srivastav sir for giving some time from his busy schedule. And Sanjay Mukherjee sir, I cannot express in words the time that you have given. I understand it was 6:30 a.m. in morning, and you might have woke up early just because of this meeting. I'm highly indebted for you. Thank you very much.
Thank you very much. It's a pleasure.
Yeah, it was really a pleasure, and it added to our forum also. Thank you very much. And with this, I request everyone, we can now leave this meeting with the promise that again we will join maybe in some other related topic, and we will certainly exchange our views. Before leaving, sir, may I request, there was one about the training videos. If you can share those, that would be helpful for our participants. So thank you very much.
Sure. And like I said, I've sent you the link to the presentation itself, so you can share that with the forum.
Thank you, sir. I'll certainly do it. Thank you very much. Now we can leave this meeting. Bye.
Thank you, everyone.
Thank you.
Thank you. Thank you very much.